Hello everyone, it's Melissa Sweet, Public Health Journalist reporting for Croaky News from the National Rural Health Conference. With me here is Phil Edmondson from the Tasmanian Primary Health, one of the PHNs, now getting underway right around the country. We've just had a very interesting discussion in a plenary session, some of the challenges and opportunities facing PHNs. So Phil, just for those joining us who aren't familiar with PHNs, could you give us a little bit of a history? And for viewers, it's important to know that Phil has a lot of experience in this area. He's worked in primary health care from the days of divisions of general practice. He's been involved with running Medicare Local and now running a PHN.
Okay, so primary health networks are what we might term the third iteration of organised primary care in the Australian context, and I guess they are probably what we would term the most advanced. There are 31 of us across the country, and essentially our role is to work at the local community level to establish and set up decision-making structures around the investment of primary health care dollars in the Australian community. We have a number of sort of core programs that we work to and a number of core responsibilities that we're required to deliver on. But the basic premise of those is that we apply a commissioning-based approach to the determination of how investment funds in the healthcare system are distributed and managed across the system.
So what are some of the types of services that you will be commissioning or are commissioning?
Okay, so we have a large responsibility in the mental health area, and this involves services that go right from the early intervention end through low intensity service through to moderate intensity, so the services that were once funded under the ATAPS funded model in Australia, through to higher order, what we might call a tertiary preventative service, if you like, higher complexity service for the community. And basically those services are a significant chunk of the mental health service delivery in the primary care sector outside of core general practice or outside of private psychology or counselling at community level.
So are you mainly commissioning individual providers or organisations?
Generally speaking, our focus is on getting services to communities, and the range of models that primary health networks use vary depending upon the type of location in which they exist. So the more rural, if you like, or the more remote of the primary health networks may well be commissioning individual providers to provide services. The larger areas, the urban areas or the larger rural areas may well be commissioning organisations that will deliver services through a range of their own employed providers to individuals. So it really does vary, and there is no one size fits all requirement for PHNs to be working to.
And you made some sort of powerful analogies, I guess, for the challenge of the job facing you. That you said that you're a very little fish in a big sea.
I guess it's cognizant of the fact that the Australian healthcare system, at hundreds of billions of dollars a year, is a massive system. It's a Queen Mary of a system, a behemoth, if you want to look for superlative terms. We are a very small investment, from our own perspective. My own PHN is around $38 million a year. So in reality, we're only a very small investment in a big system. Our change tools, if you like, are largely influence, partnership, leverage, and the opportunity to actually evidence value and evidence benefit at community level. We don't have the capacity to actually buy change in the same way that major government can when they make large-scale investment.
And yet you said the PHNs are expected to be disruptors.
Well, I guess this is it's an interesting one of those catchy modern terms. And disruption in our sense means asking questions about are we, and when I use the term we, I'm talking about are the Australian people, are the communities that we serve getting the outcomes that they need from the services that are provided. We've had a very provider and a funding-centric thinking to our system for a long period of time. This is about trying to get that shift so that we get a partnership between providers and patients in ensuring that the right services get to the right people and they get the right outcomes for those people. And that's ultimately, I guess, what our disruptive role is. It's asking those questions, and it's being prepared to make some of the tough decisions about where the best bang for the buck can be achieved and where the needs are most demanding of the limited resources that we have.
So in a sense, it's about disrupting power and hierarchies into new ways of working, and that's often very uncomfortable for change agents. You gave us some small insights into a baptism of fire that you've been through. Can you describe some of the kickback that you've had and what you've learned from that?
Sure. I guess when we use the term kickback, I suppose it's important to understand the context in which that occurs. Asking tough questions inherently means that people respond defensively in many cases. Asking, are we getting the right investments, immediately sends shivers of concern through the the funded sector, saying, oh, are we going to get our resources anymore, or does that mean the end of our service or otherwise? So inherently, I guess it wasn't an unexpected response to receive. But the reality is that we have to be asking those questions as a system. We've been given a responsibility to commit to our fund of the federal government that the money that we have is being used in the most responsible way. So we not only have an obligation, we have a responsibility to ask those questions.
You mentioned you'd had critique and so on from both journalists, media and politicians.
Sure.
So I'm just thinking, what are the learnings of that for other PHNs and other change agents in the health system? How do you manage?
Yes. Yeah, well look, I guess change never comes easily, and in a system the size of and the nature of Australia's health system, it's to be expected that there will be significant resistance. The reality for us is that our learnings were principally around the need to take everybody with us, politicians, community, detractors, and supporters alike. You can't simply rely upon the fact that a role buys you the right to make change if you're not able to actually articulate the rationale and reason for that properly. And I think that's a significant consideration in the context of how we actually approach the task that we have. From a commissioner's perspective, that means ensuring that we've got the time and the process in place to do that properly. And it also means being able to understand and recognise that different people from time to time will respond in different ways. Ultimately, our decision making has to be apolitical. It has to be free from political influence. Whilst we recognise that it's through our political system that we gain the resources that we get, and the policy settings that we work to are set by our political system, and we need to honour and respect that. We also need to be able to make difficult decisions when they're required without the fear of actually having to be pilloried for that in some respects, because tough decisions sometimes need to be made.
So could you give us some specifics? What are actually some of the specific hard questions you've asked of what type of services, and
Sure.
and I guess some specifics about what difference that might mean for community.
Well, I guess in the context of our work, we base our initial decision making on assessment of need, and assessment of need is based on data analysis. So each PHN undertakes quite significant needs assessment and prioritisation of needs at the local level. That then drives, an assessment of how services are currently being provided within that space, under each of those priorities, and a determination about what model of care is going to best deliver those services. So we need to ask questions at each of those levels. There is no one question, I guess, that comes to mind as being the difficult question. All of them are complex questions, require quite intensive process, and the commissioning responsibility of PHNs is to take stakeholders, communities and providers through that process to arrive at the end, which is an objective capability to make decisions about where the best investment of resources can be made.
So at the end of the day, how will we know you've done your job? What will be some of the indicators from the community's point of view, not necessarily federal government or...
Fantastic question. The reality for PHNs in a commissioning sense is that it is this particular question that is the crux of the issue. This is the big differentiator between old style contracting, set and forget contracting you might term it, where resources are handed out under a contract, you report back once every 12 months and you tell them and you report against your process indicators and someone ticks off and hands you your next cheque. The simple fact is that in a commissioning relationship, the relationship between the funder, and in this sense it's the PHN, and the provider providers is a continuous relationship. It's a continuous relationship that is constantly asking questions about how providers are faring against the outcomes that they committed to, and it's a relationship that allows us to work progressively and in a more flexible sense to allow them to change direction as direction needs to be changed, to allow them to flex their service delivery models as circumstances require, and ensures that what we are doing is setting a process that is constantly keeping tabs on and helping to respond to emerging community needs as they change.
Just to change tack slightly, we've been talking very much about services, and yet at this conference and everywhere else we always hear about the social determinants of health accounting for such a large variation in health outcomes, and obviously a huge issue in Tasmania as well, as you made the point. So what's your agenda around social determinants of health?
Yeah, I guess, and this is a critical question for all PHNs. In responding to community needs, it's important to understand what drives the health needs at the local level. And this changes, across communities, across different populations, across regions. When you're talking about a population that is significantly ageing, it may have lower than average academic levels in terms of its education of the population. When you're talking about unemployment being much higher, all these are the types of social determinants that impact quite heavily on health care outcomes for individuals. Any service response needs to have its mind turned to and its capacity attuned to the context in which it works. And to simply be blind to that is going to effectively fly in the face of logical, sound decision making.
What can you do about the social determinants?
Well, what we can do is to ensure that the providers that we commission and that we establish are mindful of and are capable of understanding and responding to and working with other providers and other services at that local level. So one of the requirements in many of the PHN contracts is for networks of providers to be established, for networks of service providers to operate locally to understand and build that capability at local level. I still think there's a lot of work to be done. Health policy more broadly needs to be much more reflective of a social determinants approach. And I think this understanding is becoming much more the flavour of discussion at every level in our system, from tertiary through to primary services. And it's important that we pay good attention to the impacts and needs that understanding provides.
Just to change tack again, we had a very powerful presentation from Janine Mohammed, CEO of Katzenham, the Aboriginal Congress of Aboriginal and Torres Strait Islander nurses, painting a vision for 20 years into the future where Aboriginal and Torres Strait Islander people knowledges are centred, free of racism, cultural safety is embedded into our society, not something we're taught at health professional training. Did her words have any impact on your thinking about PHNs?
Yeah, look, absolutely, and look, I used the term partnership before, and we are very heavily dependent on partnership, and partnership with the Aboriginal sector is a significant responsibility and an obligation for PHNs. Working across and with the Aboriginal community-controlled sector, who, incidentally, harking back to the social determinants of health question earlier, they're the pioneers of that. They do that so well. We have much to learn from the way in which they approach delivery of services for their communities. And from a PHN perspective, we need to be establishing and embedding, if we haven't already, and I know PHNs are all working very hard at this, very strong relationships with the Aboriginal community-controlled sector, and a more broader understanding of the impact and awareness of cultural safety and appropriateness on services in the mainstream as well.
Terrific. Now I know you have to catch a plane, so thank you very much. It'll just take me a second here to sign off, if you'll just bear with me.